So good evening and welcome to one and all. I'm Srevshi, the assigned moderator from Clarinet. Clarinet is India's most trusted and widely used digital platform with multiple enriching services for doctors. Clarinet is very proud to be a part as a digital partner for this event organized by Indian Association of Clinical Cardiologists, Jharkhand. And the topic of today's session is sexual gratification in cardiac disorders. So let's begin today's session, for which I would like to invite Dr. Sheetal Nayak ma'am to take over. Kindly proceed with the talk, ma'am. Over to you. Ma'am, kindly unmute yourself. You are muted.
So we shall start the topic. As rightly said, today we are here to talk about the sexual gratification in cardiac disorders. Well, uh, this is one of the basic instincts of animal. Man is a social animal, and it is the need of a human being also, both males and females, to have sexual gratification, and more so it is a sensual gratification because it involves all the senses of the body. So the importance of this topic is being that the young individuals who are suffering from acute MI, which is quite not very rare these days, and they have some myth whether they can be sexually active or not after having an acute MI. Somehow, this is a neglected area both from the patient side as well as the doctor side. And since this disease is quite common in younger age group, even in age group of less than 40 years, which is quite unfortunate. So with this basic idea, we are here for this particular topic today. Well, first of all, let's begin with a question that how many of we doctors ask our patient about his sexual life post myocardial infarction, post revascularization, or if he is having any cardiac disorders. Do we really feel that this is also an important issue which should be addressed by a doctor and not somebody else? It should not be left just to family and friends or some quack who may not be knowing or may be misleading, rather than a proper management which is required, a counseling which is required, that should be done. So let's answer ourselves whether we are asking this question to our patients. To begin with, we have a patient who is married and young, 36-year, who suffered from inferior wall MI and had plasty for coronary revascularization in right coronary artery with normal ejection fraction of 60%, with TMT of 12 meds, asymptomatic, 2 months post plasty. But he is suffering from a myth that stent means no sex. And this led to his divorce post PTCA because of absence of sexual activity, and he did not undergo any counseling. This particular case may be holding true for males, but this scenario is not uncommon even in females, though we understand that premenopausal time period, females are less prone to cardiac infarctions, myocardial infarctions. So this may not be very common in females, but this myth is there in females also, or the partner of the person suffering from MI. So what are the cardiovascular changes which might result, or the dysfunction post MI The results from this particular study, the NIH, National Center for Biotechnology, information which we get, that coronary heart disease patients do experience dysfunction in the sexual life because of fear of another myocardial infarction. So they have a fear in themselves that a person who has suffered from coronary artery disease or a myocardial infarction, if has sexual disorder, might have another MI, or he might have some side effects of medications. But the studies have shown that there are few cardiovascular changes during sexual activity. So this study said that sexual dysfunction in itself has a negative impact on the life of the people, and therefore they require good guidance to the individuals who suffer from cardiovascular diseases, specifically post MI. This is a crucial factor in determining the quality of life and should be incorporated in clinical practice. So we clinicians should take an initiative when we are seeing our cardiac patients or diabetic patients and need to counsel the patient about this particular part of the life. Also, the management of sexual dysfunction would traditionally involves the psychiatrist, urologist, gynecologist, and dermatologist, but this may not be true. The scenes have changed, the scenario has changed. There's a growing need of the clinical cardiologists, the general practitioners, who should also talk about it if there is coexistence of cardiovascular disease along with the sexual dysfunction. The studies have shown that it is safe to resume sexual activity post myocardial infarction. In the recent journal published in American College of Cardiology in September 21, the European Society of Cardiology also suggests that returning to usual levels of sexual activity within few months after an MI has a positive impact on long-term survival. It also suggests that this is a marker of well-being and resumption of the normal sexual activity soon after myocardial infarction is depending on the self-perception of the individual as a healthy, functional, young, and energetic person, which improves his quality of life and helps to lead a healthier lifestyle in general. Maintaining or increasing the frequency of sexual activity within 6 months post MI is associated with almost 40% decreased risk of in comparison to those who abstain from such activities. The European Journal of Preventive Cardiology also suggests that resumption of sexual activity frequency within the first month post-MI improves the long-term survival, highlighting the need for the counseling within a short span post-myocardial infarction. Now, there's a wonderful explanation or correlation between exercise and the sexual activity. If a person is able to walk slowly while exercising and he is comfortable doing that, he can go ahead with kissing and touching. And if he is able to maintain a regular pace, he can go with oral sex and masturbations. If he can be a little more faster, medium pace of walking, he can go for intercourse. And if he can cross a street faster, he can have a good orgasm, and a comfortable pace is comparable to the post-orgasmic period. Now, this concept is known as etomy, kissing, touching, oral, masturbation, and intercourse. It is related to the coitus, which is a major aspect of the health-related quality of life and considered to be one of the most pleasant and rewarding exercise during an entire lifetime. This is rational for the exercise prescription, and it should be well tolerated in stable patients, even with cardiac disorders. Even in more debilitated patients or sicker individuals, the basic things like kissing and touching may be feasible and desirable. Lower death rate have been reported in some specific groups like females or aerobically fit individuals and asymptomatic individuals with congenital heart disease. Those patients who undergo counseling with reassurance and adequately informed about this correlation can resume their habitual sexual activity post cardiac events or procedures in a stepwise manner, starting with kit to ketome to ketomy, and this can help to improve their quality of life. If we try to classify the patients into low, immediate, and high risk, a stable angina with controlled hypertension and asymptomatic should be allowed for ketomy, whereas immediate risk who have moderately stable angina and uh, uh, there is no minimal risk of induction of symptoms during coitus, then maybe he can limit himself to ketone, avoiding coitus, and those at high risk should be restricted to just kit rather than going for the penetrative activity. The circulation also published US guidelines that sexual activity may be resumed within a week or few weeks in an uncomplicated acute myocardial infarction without any symptoms during mild to moderate physical activity. The European Society of Cardiology suggested similar thing and said that sexual activity should not be delayed if the patient is able to tolerate the physical activity. So we see here that these two things, physical activity and the sexual activity, are very well correlated in various guidelines, which can be a good marker to resume to the normal pattern of life. If there is any coital angina, as they say, within minutes or hours, then there is less than 5% of risk of anginal attack, which is not so common. And such person may have such symptoms during strenuous exercise also. It's more prevalent in those patients who have severe coronary artery disease or unstable angina. Angina with minimal physical activity should limit themselves, and those patients who have 3 to 5 minutes without demonstrating ischemia, the risk of ischemia during sexual activity will be very low. If we talk of coronary artery disease, in mild angina or no angina, probably patient can go back to normal level in a period of more than a week post uncomplicated MI if the patient is asymptomatic. After complete coronary revascularization, 6 to 8 weeks after CABG and few days post PCI, normal activity can be resumed. Of course, one of the basic requirement will be a good, well-healed sternotomy wound. In a non-coronary open heart surgery, once again the patient can resume the normal lifestyle within 8 weeks once the sternotomy suture is healed. An incomplete coronary revascularization will depend on an TMT test, which can be done to understand the residual ischemia, and accordingly, if the patient has unstable or refractory angina, the sexual activity can be deferred otherwise and sent for an optimal medical management before a normal coitus life is taken over. Now, coming to these three criteria: stable ischemic heart disease, post-PCI patients, and previous MI. A post-PCI, a post-CABG, and non-coronary open heart procedures, usually the patient takes to the normal sexual activity within 2 months of CABG. And of course, the sternotomy suture should be healed one. After post CABG, the satisfaction is maintained in most of the individuals in an heart failure patient who have compensated heart failure or mild heart failure like class 1 or class 2. Patient can resume the normal lifestyle, but it is not advised in decompensated heart failure, and patient should be stabilized and optimally medically managed before he gets back to his normal quieter life. The similar thing holds true even for valvular heart disease, that in mild to moderate stable asymptomatic patients, normal life can be resumed, whereas it should not be advised in symptomatic valvular heart disease unless and until patient is stabilized and optimally managed. Coming to the congenital heart disease, a decompensated or advanced heart failure should defer the coital experience, and an asymptomatic one can resume his coital life. Similarly, for arrhythmias, post pacemaker implantation or defibrillator implantation in patients of AF who are well controlled ventricular rate and atrial rate with a history of AV and RT or re-entry tachycardia or atrial tachycardia with controlled arrhythmias, or post PPI or ICD implanted for primary or secondary prevention without any symptoms with minimal shock, patient can resume the normal coital life. So tolerability is the key to the success. It should be deferred. The coital life should be deferred in patients who are poorly controlled in terms of ventricular rate or AF, or are symptomatic for supraventricular tachycardia, or have spontaneous VTs which are exercise induced, should be referred for optimal management before coital experience is taken over. If a patient is receiving multiple shocks when the ICD has been implanted, there also the coital experience should be deferred. Coming to the HOCM, here also we suggest that a stable patients may be taken for coital experience, but unstable patients should be deferred and should be sent for medical management. Some of the cardiovascular drugs are known to have an adverse effect on sexual function, so that should not be withheld if that is need of the patient. Like beta blockers, they say may reduce the libido, but such patients should in such patients cardiovascular disorders, if beta blocker is required, it should not be withheld, that has to be continued. And because that will be the one of the key factors in maintaining his normal cardiovascular function. In such scenarios, local or topical estrogen therapy, which are non-systemic drugs, can be used in females in dyspareunia if the cardiovascular disease is well stable. Some of the herbal medications are also being used, but we do not have its details in terms of ingredients, and that is why that can be questionable at times. But some of the basic ingredients in our kitchen, like saffron, that is kesher, fenugreek, that is methi, asafoetida, that is hing, garlic, that is lehsun, onions, that is pyaj or kanda. These are some of the basic things which are being used routinely. Garam masala, which is quite commonly being used in our day-to-day life. Then we have cinnamon, that is cinnamon. So these are a few common things which we are using in our day-to-day life, and that helps to improve the libido. So along with these natural things which are a day-to-day use in our kitchen can be helpful, along with the counseling both for the patient, male or female, and the partner, male and female, because this mental hindrance is one of the biggest cause, specifically in newly diagnosed cardiovascular disease or post management, like any intervention like coronary revascularization or ICD implantation, etc., or CABG. So in such scenario, that is probably the most important thing, that is counseling for both patient as well as a partner is very important. Coming to the PDE5 inhibitors, which is one of the potent drugs which is being used specifically in erectile dysfunction, which may be used in cardiovascular disorders, but it must not be used along with nitrates. That is one important thing. And also potassium channel openers, that is nicorandil. Its safety is also not very much clear in patients of hypertrophic cardiomyopathy and aortic stenosis. So better avoid in these specific situations the PDE5 inhibitors. So to summarize, we can say that counseling is the key to the management of sexual activity in cardiac disorders. In general, a stable patient may resume normal coital activity within 2 to 6 weeks of the procedure, or in sternotomy patients maybe up to 2 months. We must ensure stability of the patients in terms of being asymptomatic. His wound should be well healed up. If we have any doubt, we can go for exercise stress test. Clinician must be alert and open-minded and should check about the medications which patient might be taking, or the some OTC management which patient may be taking, like PDE5 inhibitors without our prescription should also be taken into consideration. We must check whether the patient is taking any herbal things without known constituents which may be harmful for him in terms of any side effects or for the cardiovascular disorder. So that should be taken into consideration. Any symptoms like palpitations, dyspnea, angina, or fatigue during coital activity should be evaluated and looked for. Physician needs to be proactive so as to have proper counseling and assessing regarding his coital life. In general, an individual with 5 minutes on exercise treadmill tests without any symptom can resume normal coital activity. Similarly, an echo which does not yield any evidence of left ventricular dysfunction is probably safe to resume his coital activity. With that, I would like to thank you all for patiently listening. Any questions are most welcome.
Dr. Vineet, very good presentation. Thank you very much for updating on this very unfamiliar topic. And so the take-home message, after PCI, how many weeks? After CABG, how many weeks? Can you just simply tell, after PCI, 2 stents, how many weeks? After CABG, after stenotomy, wound is clean, how many weeks?
Post PCI, if the patient is asymptomatic, maybe after a week or so, and post CABG, at least 1.5 months, it will be time. And another important thing is we must ensure that the sternotomy suture is well healed. So that takes about 6 weeks time. So that is an important consideration before going for complete coital activity.
So post PCI 1 week, post CABG 8 weeks, correct?
8 weeks.
And do they need a TMT before coitus, or this time period is well enough?
Generally speaking, if we have complete revascularization and patient is asymptomatic, we may not require TMT. In severe disorders, we may require TMT, or if the patient is symptomatic. One of the simple things that Kitomi thing comparing with walking can be a burden like thing for the patient, that if he is able to walk his routine walking, um, and depending on that pace we can also assess, and if we have doubt we can go for TMT, but otherwise
Okay, thank
that
you very much.
Kitomi thing
And
comparing with will be sufficient.
okay, thank you very much.
We have here one question from Dr. Sarthak Sahu. How to maintain a stable heart rate without reducing libido in cardiac patients? Very right. We have a few things in our mind that in general in cardiac patients, we use beta blockers. Now, if this is a concern, then we can go for selective beta blockers like maybe nebivolol, that can be a one choice, or even if nebivolol is also becoming an issue, generally this is not, then we have ivabradine also, which can help to reduce the heart rate without reducing the libido. Another question we have, how many meds are spent in male and female masturbation and copulation respectively? To be very frank, Dr. Sahu, I do not have answer to this question. Maybe I will have to look for it and then we can answer that. Talking of meds, I can say that 3 to 5 meds, if they say the patient is able to do, in that scenario, the patient is safe to go for coital activity. But this particular answer, I need to look up and then get back to you. Any other questions? If any other audience can answer that question, I will be thankful about the meds spent during female or male copulation. What medications are safe in arrhythmia due to sexual activity? In general, we go for beta blockers once again, and if we are unable to, if that is becoming a hindrance, we can go for ivabradine as well as antiarrhythmic drugs rather than beta blockers.
Good evening, all of you. That was a absolute wonderful presentation about sexual activities related with cardiac activities. Am I audible?
Yeah,
Yes,
ma'am.
ma'am. Yeah.
Yeah. These are topics which are otherwise not discussed very openly, and neither the doctors openly question the patients about. So I am first of all thankful for taking up this topic. And one question I would like to ask is, there was a patient I had around 2 years back who said that she used to have sudden onset of headache only during sexual activities, but her blood pressures otherwise when we used to check used to be around 120 120 80 or something like that. And then she was evaluated for each and everything, like including MRI, and MRI brain also was done for her because she used to have throbbing headache during sexual activity. Later on, it was found out, like after doing all set of investigations, we found out she had only diastolic hypertension. And after starting her on antihypertensives, a very small dose of beta blocker, her headache went off. So how do we explain this? It was related that she had her blood pressure would shoot up during sexual activity, and that's how she would have a headache, sudden onset headache. Was that the reason
Yes,
after the blood pressure came under control? Yeah.
I understand that isolated diastolic blood pressure could be one cause. Another could be stress. And generally, we ignore the stress part, that maybe she is not very comfortable due to the environment, surroundings, or some behavior of the partner, or some issue which might be there. This aspect also needs to be addressed along with the medication and the medical part, that is the diastolic blood pressure, which was evident in this particular scenario. So definitely diastolic blood pressure needs the management that should be done, and a counseling is equally important in such patients.
Dr. Vineet, hear me?
Yeah.
Yes,
Yeah,
yes.
regarding the meds, it is written in one study. It indicates that the energy expenditure during sexual activity appears to be approximately 85 kilocalorie or 3.6 kilocalorie per minute. Seems to be performed at a moderate intensity, 5.8 METs in young healthy men and women. It's about
Thank you.
in young healthy. So 5.8 METs.
Thank you so much, Dr. Vishwajit Sahu. We have answered for your question that 5 to 6 METs, to be precise, 5.8 METs is the answer for this particular question of masturbation and copulation. Thank you so much, Dr. Rajesh, for enlightening us. Thank you so much. Any other question, any other comment?
So, Dr. Vineet, thank you very much. I have to leave. I'm really sorry. I want to be here more, but unfortunately, I have to leave. Thank you very much for inviting.
Thank you so much for being here. I guess if we have no questions, we can wind up. Sheetal ma'am.
Yes. Thank you, Dr. V K Jagnany. This was a wonderful talk. Hope to be getting much more of such enlightening talks. Thank you very much. Thank you.
Thank you so much. Thank you, Shreyasi. Thank you, Dr. Kapil. Can we take a
Thank you
leave,
so much.
Shreyasi
Yeah,
ji?
sure, sir, sure. Thank you so much for giving us the opportunity to host the session. And we hope to have you again on our platform very soon. Thank you.
Thank
Good
you.
night, sir.
I request to kindly share the link of recording with me.
Yeah,
Maybe on
sure. Our
WhatsApp or
our
mail.
concert team will share with you, sir. Thank you.
Thank you so much, Shreyasi. Thank you so much. Taking your leave now.
Yeah, sure.
Thank you all the delegates. Thank you all the faculty. Thank you so much.